So you might say, okay, I'm not going to be performing chemotherapy or radiation or surgery on someone. What is the role of physical therapy in cancer? So, hey, let's talk about it. So obviously there's not any of this in the text because the text is directed towards all health professions, but we're going to talk about specifically. So the medical treatments for cancer continue to improve the lives of people with cancer, but they also bring potential side effects. And we talked about some of those in the last section. The side effects of treatment combined with disease-related and lifestyle-related risks for loss of function frequently lead to a changing trajectory of physical and cognitive abilities, which may exacerbate a psychosocial disruption. So what the heck does that mean? We'll talk about it. So as therapists, we can play a vital role by helping the patient optimize their physical and cognitive functioning. We can help them in monitoring side effects of treatments and notifying the appropriate providers. We can educate our clients and their family and caregivers on anticipated changes in functioning and how to manage these changes. So, after surgery, if you're working in an inpatient setting, you might be treating someone right after surgery. So there might be postoperative drains in place. We need to, either the physical therapist or physical therapist assistant needs to take care to avoid manipulating the drains. Range of motion exercises can cause the drain to be displaced, so you have to be aware of where they are and what you're doing. Incisions resulting from muscle transfer flaps involving the rectus abdominis, pectoralis, or latissimus dorsi should be supported when the patient coughs. So we're going to have them hold a pillow when they cough. We are part of the healthcare team that is educating them on what they need to do. We need to instruct the patient in the log roll technique, which is used to minimize contraction of the abdominal muscles while the patient is getting out of bed. We are also going to instruct the patient to minimize contraction of the shoulder musculature during transfers. So the other thing that you're often doing is you're teaching their family members or caregivers how to assist them during transfers to minimize effort from the patient. Lymphedema treatment may be needed after cancer treatment. You might need to control lymphedema with lymphedema massage, elevation of the affected limb, exercise while wearing non-elastic wraps, elastic garments, or compression pneumatic pumps, especially when surgery involves lymph nodes that are near the extremities. So a lot of times breast cancer or ovarian and prostate cancer result in lymphedema in the arm or the leg. So next quarter in modalities class, we are going to have a lymphedema specialist come and talk to us about physical therapy treatment for lymphedema. And it's always interesting and educational. So this is just a specialized area of treatment that PT is very involved in. Things we need to consider when someone is undergoing chemotherapy. Nausea and vomiting after chemo can vary patient to patient. So some people have a lot of it and some people don't. And remember, we have to, body fluids might be contaminated, so we have to be aware of that with vomiting. Some side effects of chemo may be so severe as to limit physical therapy, whereas others allow patients to tolerate activity. So it's going to really vary from person to person. Definitely when you're an inpatient, your approach is different when you walk into the room of someone who just had a knee replacement versus someone who just had cancer surgery and is undergoing chemotherapy. Completely different approach. Sometimes rehabilitation has to be delayed or modified until the side effects from chemo are minimized or alleviated. So it might be that if the person has extreme side effects, we might not be able to do rehabilitation with them. Patients might be taking antiemetics, which help to control nausea and vomiting after chemotherapy. If nausea and vomiting are limiting the patient's ability to participate in physical therapy, we need to talk to the physician so they can adjust, modify, or enhance the antiemetic regimen. It might make him way more comfortable and able to participate in therapy. We need to let the patients know of the possible side effects and understand the need for modification or delay of rehabilitation. So they might say, oh, come on, I just want to do it. And we need to let them know why they should or shouldn't. But we also need to give them emotional support and encouragement when they're unable to achieve the goals that they have initially set. So sometimes just being that listening ear, being someone that they can talk to and commiserate with, can be really beneficial for the patient. Our PT interventions may need to be coordinated around the patient's medication schedule. We always want to monitor vital signs, especially when they're taking the more toxic chemotherapy agents that affect the heart, lungs, and central nervous system. The platelet, red blood cell, and white blood cell counts should be monitored on a patient with chemotherapy, because remember, if the platelets are too low, we don't want to do any strengthening. And we also need to really watch balance and anything that could potentially cause them to bleed more. Patients receiving chemotherapy can become neutropenic, where they are at more of a risk for infections and sepsis. So a lot of times they might be on precautions such as being in isolation. So you might need to gown, mask, and glove up and treat somebody in their room, and because they're in isolation. So that's something to be aware of. So chemotherapy agents can also affect the patient's appetite and the ability to consume and absorb nutrients. So if they have a decline in nutritional status, it can inhibit their progression in strength and conditioning programs. So hopefully they are being treated by a nutritionist and they can get proper nutritional support. In an inpatient setting, you might be consulting with the nutritionist to plan the appropriate activity level based on the patient's caloric intake. So one of the side effects of cancer treatment that can show up in PT even years after they've had chemo is cardiotoxicity. And cardiotoxicity, which is also sometimes called cardiac toxicity, refers to damage of the heart muscle or electrophysiology from harmful chemicals that are used in chemotherapy. Certain chemotherapies and targeted therapy drugs and radiation therapy across the chest are known to cause cardiotoxicity, which might lead to cardiomyopathy, which is damage to the heart muscle. Examples of heart damage include death of normal cells around the heart, enlarged, weakened, or stiff heart muscle, myocarditis and pericarditis, and we're going to talk about all the cardiac disorders next quarter. Blood vessel damage and acute coronary syndromes, congestive heart failure, or cardiac arrhythmias. So cardiotoxicity is a potential side effect of cancer treatments, either chemotherapy, targeted drug therapy, or radiation therapy. The cardiotoxicity may develop during the treatment or in the days following. It may develop months or years later, and even once someone is cancer-free or in remission, they can develop cardiotoxicity. So it can be anything from subclinical myocardial dysfunction, meaning there's a little bit of dysfunction but you don't have any symptoms, to irreversible heart failure. So there might be no symptoms at all, or there may be complaints of chest pain, rhythm changes, increased fluid retention, or fatigue. Treatments for cardiotoxicity typically include treatment from a cardiologist or cardio-oncologist, using diuretics to control fluids, using ACE inhibitors or beta blockers to control blood pressure, and using drugs like digitalis to regulate rhythm and make the heart stronger. So the most common report that a patient in physical therapy will have, they're not going to say, oh gosh, I have a cardiac rhythm change, the most common thing that they're going to report to you is excessive fatigue. So if you have a patient that you know is undergoing or has undergone chemotherapy and they report to you excessive fatigue, you need to refer them to their cardiologist or cardio-oncologist. So the things to remember is to just remain aware of your clients' or patients' previous or current cancer treatment. So you should know what's going on when you take the medical history. You want to know about their risk for cardiac changes related to cancer treatments, and you want them to know what their baseline heart rate is at rest. You don't necessarily need to take it continually, but you need to monitor it frequently if there are signs and symptoms of heart dysfunction, which is usually fatigue. So you want to report any changes immediately to the oncologist or their primary care physician, including increased fluid retention, swollen legs, feet, or ankles, or if the patient just says they feel bloated, if they complain of coughing spells or a chronic cough, if they have trouble lying flat or complain of shortness of breath, that can be indicative of congestive heart failure. If they complain of feeling overly tired or fatigued, that's not consistent with the level of activity that they're participating in. So that's probably the most common thing. Those 4 things are probably the most common things you're going to encounter that the patient's going to tell you about. If you suspect cardiotoxicity, you want to report your concerns to the appropriate physician. And you want to encourage your client to follow up with the cardiac oncologist or their regular oncologist. You want to caution them against their own self-exercise or home program and exercise classes. A lot of people just want, I just want to work through it. You want to avoid just working through it until they are cleared by the cardiac oncologist or oncologist. So it's really common for a patient to be deconditioned following periods of inactivity, such as during a hospitalization. And that deconditioning might also show as a heart rate that's high in relationship to the activity being performed. So it's important to distinguish between deconditioning and cardiotoxicity. So when in doubt, always consult with the physician. So if you have any misgivings or doubts about this patient, contact their physician and let them figure it out, because we don't want to make things worse. So the cancer-free state is generally defined as a 5-year survival without reoccurrence. Some cancers, such as childhood leukemias, can be considered cured after a 10-year cancer-free period. Remission means a person has no clinical signs of cancer, and they may experience several remissions. The life expectancy and death rates for specific cancers vary. So this is just some examples of the prognosis for malignant tumors. So skin cancer is usually visible, and it's easily diagnosed and treated. And there's generally an excellent prognosis, with the exception of malignant melanoma, because it metastasizes, so it has a worse prognosis. Ovarian cancer has a poor prognosis because it's internal. There's not an obvious tumor. It's hidden. And there are high mortality rates with ovarian cancer, unfortunately, because it often doesn't get detected until it's gotten to the stage where it's big enough to cause problems. Then at that point, it's really a problem. Brain tumors, both benign or malignant, can be life-threatening because of compression of brain tissue. The primary tumor is usually fatal, so you don't get a lot of metastasis, although you sometimes get metastasis through the cerebrospinal fluid to the spine or other areas of the nervous system. So not a very good prognosis for brain tumors. The cancers that are most common in men are prostate cancer, lung cancer, and colorectal cancer. The ones that are most common in women are breast cancer, lung cancer, and colorectal cancer. So you could say in most people, lung cancer and colorectal cancer are the most common, and then prostate cancer for men and breast cancer for women. So just in terms of incidence, that's what you get the most of. So really what we want to do in physical therapy is we want to help the patient to maintain optimum functioning. A person's performance status is one of the key factors that determines the best treatment and overall prognosis. It's imperative for people with cancer to maintain optimal functional abilities in order to continue receiving medical treatments. If they're not strong enough to withstand the treatment, then they can't do it. Oncologists often use, there are different performance scales they use in this Eastern Cooperative Oncology group. The ECOG is just one example. And this is, basically they grade the person's performance status from 0 to 5, 0 being fully active, able to carry on all pre-disease performance without restriction, and 0 to 5, and 5 is dead. So you can see the in-between categories there. So that is one of the ways that they classify someone's performance status. There are definitely other outcome measures that oncologists will use to classify performance status. We talked about in the last module the effects of immobility, some of which are listed here. I just thought this was interesting. The study showed that 3 weeks of bed rest is similar to 40 years of aging in terms of physiological deterioration. That's horrible, really. So we already talked about this, but this is just one of the consequences of cancer treatment. It can cause increased immobility, and then you have all the potential complications resulting from then. So lots of factors that interplay in cancer that lead to changes in physical and cognitive abilities. It can be related to the disease itself. It can be related to side effects from the treatment. It can be related to the changes in lifestyle that happen when somebody's undergoing cancer treatment, or it can be something individual to the person. So lots of things can affect people's physical and cognitive abilities. Ideally, what we want in rehabilitation for everything, not just for cancer, but we want the person to be able to return to independence, or as close as possible to their prior level of function. So we kind of have to ask ourselves, well, what is independence? Some of it has to do with the person's expectation of their abilities. Did they have to drop the bar to just completing a basic daily routine? Have they forgotten what their life was like before cancer? And do they believe they can have a full life after cancer? So a lot of issues relating to independence have to do with the person's expectations. And that goes for everything, not just cancer. It goes for any kind of illness or injury. List of references like usual, and we will definitely talk more about leukemia, lymphoma, and cardiac related things, and all the different digestive system cancers next quarter.